Hi, everybody. Welcome back. We have actually we're going to bring back Dr. Peluso if he's still available because he has some slides on MPV or MPOX that if you're able to share, that would be great. So we'll take you up on that.
Sure. Yeah, happy to. Give me a second to just find it here. Are you seeing the correct slide?
Yes, we are. Thank you.
Okay. This is a brief primer on what used to be known as monkeypox and now is officially known in California as MPOX. I want to just acknowledge Peter Chin Hong, one of my colleagues who shared some of his slides for me to put this together. So basically I structured this as 5 things that we sort of hear about MPOX that I want to dispel and the current state of where things are at. So the first myth is MPOX comes from monkeys. I think it's important that whenever there's a new infection, we try to understand where it came from. And MPOX was called monkeypox because it was initially identified in some monkeys in Europe in the 50s in a research lab. But actually, like the most notorious outbreak of MPOX was in the was in the early 2000s. In prairie dog owners in Wisconsin, which has nothing to do with monkeys. And so this is actually mostly a disease of animals, particularly rodents, and humans and monkeys just are kind of incidental hosts. So it really has nothing to do with monkeys at all. The Department of Public Health in California officially renamed this MPOX like 2 weeks ago. I'm not sure if there's a coordinated effort in the US to rename it. There is a coordinated effort among the WHO, within the WHO, the World Health Organization, to rename it. Renaming it is important because, as I said, it has not anything to do with monkeys. There are lots of racist tropes related to monkeys that I'm sure you can imagine that are very problematic. And people have actually attacked monkeys over monkeypox. It's difficult to rename a disease in the middle of an outbreak. You will remember not too long ago when we renamed SARS-CoV-2, and that was much earlier in that outbreak than we are in the MPOX outbreak now. So that's myth 1. Myth 2, you can get MPOX from a thrift store. So the vast majority of MPOX transmission in the current outbreak is skin to skin. There's a lot of debate about skin versus bodily fluids. I'm not going to get into the debate, but those 2 things are thought to be the highest level of transmission. There are cases of people getting MPOX from clothing or from bedding. The most well-known case of that is somebody who was changing sheets at a hotel and got a case of MPOX before this outbreak happened. But that is not a major source of transmission. Droplets require really active exposure for a really long period of time. And it is extremely unlikely that somebody will get MPOX from just, riding the subway or the bus. Some updates in transmission. There's a case report from Stanford that suggests non-sexual contact. The vast majority of cases, as you know, are sexual transmission, either from skin or fluids among men and transgender women who have sex with men. So not a lot of other cases so far. There are cases of transmission to pets. So there was a case where a dog that had 2 owners, both who had MPOX, was sharing a bed with them, and the dog ended up getting MPOX. So, there are lots of other potential incidental hosts of this. There's been a lot of buzz lately about what's going to happen with people going back to college. I don't think that there's going to be any risk outside of intimate contact in these settings, but this is in the news now. There are some cases of household transmission to children. This is not super common. It's not really surprising because we know that close contact is what can cause it, but we're hearing a little bit more about this. But it's important to know that the vast majority is still sexual contact. And so talking about other aspects of transmission, I'm not really sure how, I'm not sure it's sending the right message about risk. Until recently, we thought that asymptomatic monkeypox did not happen. I said the wrong thing. MPOX did not happen. There are cases recently of particularly men in sexual health clinics in Europe who've had asymptomatic screening with positive tests for MPOX. Some of those individuals have gone on to experience symptoms, but some have not. What is important is that despite a lot of concern about this, as far as I know, as of now, there's still no evidence for asymptomatic spread. And that's because most of this virus lives in superficial areas of skin that are going to be symptomatic if there's a lot of virus there. The MPOX vaccine is 100% effective. That is not true. It's pretty good, but most of the data that we have is based on the earlier smallpox vaccines that have been repurposed for MPOX. There are cases of people who have exposure and get the vaccine sort of as post-exposure prophylaxis who have breakthrough cases. Generally speaking, those cases have been after they got the vaccine, a week after their exposure. We are hearing about some breakthrough cases now in people who were pre-vaccinated and got exposed, but it doesn't seem to be super common as of right now. There's been a lot of talk lately about the different administration of the vaccine. Previously the standard regimen was a subcutaneous, so below the skin dose of the vaccine. Recently, in many settings, this has been changed to an alternative dosing, intradermal within the skin of a lower dose. This is based on a study from a few years ago that showed, as you can see on the slide, basically similar immune responses regardless of the type of administration. But this is being actively studied now. And I think most of this was driven by public health concern, although there was certainly some controversy around it. And then I think the last myth is that we are definitively done with this. There's been some good news in the last couple of weeks where it seems like the curve has peaked and is trending down. That's good. That's objectively good news. It's possible that the community mobilized, vaccines were rolled out and things are improving or behaviors changed. I think we have all seen this pattern several times with COVID in the last 2 years. So I think that we still need to remain cautious and not declare victory yet. But hopefully this is a positive trend that will result in ongoing improvement and fewer people being infected. And then this just came out about MPOX in people with HIV, suggesting that there's potentially a higher rate of more severe presentations, including hospitalization. This was a recent CDC study that was published, I think this last weekend, suggesting that among people with HIV, 8% of people were hospitalized because of severity, whereas in HIV negative people, only 3% of people were hospitalized. This has not borne out in other settings, particularly in Europe. So, hard to know whether this will really pan out or it just was sort of happened to be related to who was studied here. And then Gabriel actually shared this with me over the weekend, that there's a recent report of 2 cases of individuals developing neurologic complications following MPOX. They did not have particularly severe MPOX, but did have severe neurologic symptoms. that happened between 1 and 2 weeks after initial onset. Quite concerning, obviously not that common. But I think that it sort of bears the question related to what we just talked about for 20 minutes about long COVID, about whether there can be post-acute sequelae of this infection, because it seems like for many infections that we encounter, there end up being unanticipated sequelae. And so I think we all have to be on the lookout for this. I hope that it will not be true. So it's hard to know where we're at right now, whether this is going to turn out to be all self-limited, whether it's going to have another surge and affect more and more people, whether it's going to establish a large non-human reservoir related to the many different types of animals that can be infected. Yeah, still too soon to know, although I think the current trends are hopeful. And I think for me, there were a lot of issues with the rollout of the vaccine in particular, but I think the engagement of the community, especially the community of people who perceive themselves to be at risk, at least in SF, was quite inspiring to me. And so we will see where this goes. Okay, that was my primer on MPOX. Thanks.
Thank you so much. We do have one additional question submitted. Do people living with HIV or who have had MPOX get post-viral diseases similar to fibromyalgia, ME/CFS, post-Lyme, post-polio, etc.?
Are people with HIV more likely to get those, or?
Well, the question is just overall, which we know people do, including our co-founder Gabriel is living with HIV as well as ME/CFS and fibromyalgia. But those are other specifics you'd like to say about it?
Yeah, I mean, I think the message is that post-infectious conditions are certainly real, and I think that they've always been very hard to understand because there's always been a real lack of clarity in many cases about what the inciting event was. I think that what we have learned from COVID in particular is when so many people around the world were affected by the same thing at the same time, is that this is probably what's been happening with most of these conditions. And we've never had this level of information and organization in understanding what sets it off. And so my hope, I don't think certainly not, I wish that COVID never happened, but my hope is that post-COVID issues and long COVID in particular shine more light and bring more attention to and more efforts to understand all of these related conditions that really have a big impact on people, and that we've done a very poor job of understanding and managing over the last couple of decades. So we'll see if that's true. But there is certainly a really concerted effort to figure all of this out now.
Thank you. There's a great comment from Alice K, sharing her experience looking to get MPOX test in a COVID safe way, and we'll put that in the proceedings. We're not going to talk about the comment now because of our time constraints, but thank you so much for talking on both topics. And now we're going to move on to our final two presentations.